Lessons Learned webinar. I'm so glad you could join us today. My name is Chris Wolfslayer. I'm the training manager for Access Matters. People will probably continue to connect in on the web and over the phone for the next few minutes, but since we have a lot of material to cover, we'll go ahead and get started. A few brief housekeeping items. If you're having trouble with the webinar software, please know that it is being recorded and will be made available online in approximately 1 week. If you can connect to the webinar and the audio portion but get kicked off at any time, just reconnect using the instructions provided in the email that was sent to you. You should have received an email this morning containing a copy of the presentation, a sign-in sheet, an evaluation form, and a fax cover sheet. We ask that everyone sign the sign-in sheet and complete the evaluation. I included the fax cover sheet just so you can send it back at more of an ease. After the webinar, I will compile a list of who attended for reporting purposes. So it's important for us to know who attended. Background noise is a big problem on webinars, so for this reason, we have everyone muted. If you have a question, please type it into the chat box on the right side of your screen. At the end of the presentation, we will read the questions to the speakers, and they will address them as time allows. So I am now going to hand this over to Nancy Smit and Chris Perkey from SHR Associates. Thank you.
So good morning, everyone. Good morning. Nancy Smit and Christine Perkey. Thank you, Chris Wolfslayer and Elizabeth Lebo. We're really excited to have this opportunity to share some of our lessons learned by our activities out with your various health departments over the past several years. As most of you know, it sounds like this is primarily a Maryland-based audience, and our firm, SHR Associates, has had the opportunity over the last 2 to 3 years to actually visit all 24 local health departments, initially looking at billing readiness for immunizations and now moving more into STD, family planning, and some HIV services. So we were asked to share with you today, using the components of the revenue cycle process, what we have seen out in your departments, both the things that are going well and opportunities to strengthen components of the revenue cycle process as you all prepare for billing. So that's really the process we're going to use today, is to use the components of the revenue cycle process and then share with you, primarily Chris Perkey has led our teams to the various health departments. So I'm going to go through the revenue cycle process, and Chris is going to chime in with things that she's seen, those that work well, and ways that we hope you can continue to enhance your efforts to collect revenue for your services. So I think with that, we will move forward. Just a little bit about our firm and my background and Chris's. We have both been in healthcare for, should we say? No. 25 to 30 years, focusing both on the private practice side as well as the public health side, and really helping organizations, as we say, bring the business side of their operations up to the quality of the clinical care. So today, we're going to go through the revenue cycle management process. We're going to talk about how each of the components affects the next and the overall success of your billing efforts. Insert where we have identified opportunities to strengthen your billing process for each component. Briefly talk about some of the key performance indicators, the KPIs that you can use to help monitor and accomplish process improvement. And at the end of the webinar, we've provided you some additional references and resources that we'll share with you. So wanted to make the point that billing really is a team effort, and we like this description of a team, that it is a group of individuals working together, striving to achieve a common goal that they all believe in, and that would be difficult, if not impossible, to achieve by people working alone. In the past, billing has very much been seen as kind of a back office effort, and today with the challenges both externally and internally to maximize revenue, it's really important to appreciate that everybody in the organization needs to understand how their role and responsibilities impact the success of the billing process. So it truly is a team effort, and I will kind of talk that through a little bit more as we go through today. So for review, the components of the revenue cycle really break into both front-end and back-end processes, and here are the components we'll review today: front-end process and back-end process, and now we'll begin. So the appointment scheduling process is really the first step in the revenue cycle process, and it helps you set up the account for both billing and patient contact. There are now electronic systems, if you have practice management and EHR, that greatly enhance that and really help to kind of prompt you to make sure that you get both complete demographic and insurance information. I'm now going to turn it over to Chris, who's going to talk a little bit about what she's seen out there relative to the challenges and opportunities.
Yes, I visited most of the health departments, and what I'd see is sometimes there was centralized scheduling, and sometimes the scheduling was performed by each one of the individual departments. Some of the scheduling is on practice management side, electronic scheduling, and other ones were still on paper and trying to monitor it that way because they didn't have their practice management system up, or they were not comfortable, or not at all. The other thing I noticed that there were some clinics that actually had only walk-in services, especially for their STI clinics. Now keep in mind, when I went to visit the clinics in the health department, some of the clinics were combined family planning, STI, some of them were individual, they were separate clinics, and some had even the HIV clinic combined in with the STI clinic. So, you know, we notice that, we take that, and I hope you take that into consideration as I'm talking through this, because it depends on how your structure is set up as the appointment scheduling. But what we identified is when you have walk-in appointments, you have very little control over how your clinic day is going to go. You have long waiting periods. I had one clinic we talked to, and they had waiting periods up to 2 hours for their patients. They didn't know how to staff their clinics. You know, if they were going to have a busy day, obviously you can have more clinical staff available. So the entire office flow, because they were doing walk-in appointments rather than scheduled, it really bogged it down and prevented it from being efficient. So one of the lessons we learned here, and I think most of those clinics that were doing walk-in basis have now modified, and they're doing appointment scheduling. Obviously, with the type of services that you provide, we realize that you do need to have some same-day appointments open or allow some walk-in appointments, which most offices are accommodating. But by scheduling ahead of time, you can reduce the, improve the flow of the clinic and obtain that patient contact information that you do need.
Okay. So when you have the opportunity to schedule the appointment in advance, it also gives you then the ability to do pre-registration and authorization when it's needed. So verifying the eligibility of your patients with insurance and obtaining authorization for specific services really helps to identify whether you have missing or inaccurate information in advance, and helps truly to ensure that the patient, the services that are requiring any type of pre-authorization are covered or paid.
When we visited most of the health departments, they did not pre-register patients. So they did not obtain that critical information as far as billing, address, so that they could authorize and pre-eligibility with their insurance companies. Some of the reasons were because they're not billing yet, and there was no reason for them to take and get that information. The other reasons were that confidentiality. So those were some of the concerns that the health departments had about pre-registering. They really were not in tune to gathering that information. But as we move into the next cycle and the environment changes with healthcare and that you are going to need to bill, obtaining that information in advance of the appointment improves the clinic flow because it doesn't cause a backup at check-in when patients are coming in. Authorization, I did want to point out, obviously there are some services that you don't have to pre-authorize or obtain authorization for, but we do know that there are several that you do, and especially with the HIV clinics, in order to get paid when you're not a participating provider of a managed care organization, you need to get authorization in order to obtain reimbursement. This was something that you would eliminate if you contract with your MCOs and some of the payers. So it would reduce that function, the necessity for that function in a lot of ways if you do register with the payers in contract.
Just want to make the point that those of you that have practice management systems, that much of this can be done online. It used to be a very labor-intensive process, you know, sitting on the phone, but now this is automated for both pre-authorization and eligibility verification. So if you do have practice management systems and you're not using these functions, check with your vendors, and I would imagine that you would be able to accomplish that in a fairly efficient way, and again, it helps with best use of your staff.
I also want to add that when I typically go into a health department and we look at their functions and their revenue cycle management, we like to look at the back end sometimes even before the front end. And the back end really shows us what's not happening at the front end because it's a whole cycle and billing begins at the front end. So the more information that's obtained in advance, the lower your denial rate's going to be, you're maximizing your revenue, and the workload's really shifting now from the back end to the front end. And we will talk about that a little bit more.
Okay. Reminder calls, again, this is really only relevant if you are making appointments, but it's certainly if you do, it greatly reduces the chances for no-show, provides a real opportunity to discuss some of the payment and sensitive issues that then can be discussed in advance and don't have to tie up the check-in process or happen at the time of the visit. And again, this is a function in most practice management systems that can be automated.
We did realize that when you're in an STI clinic, family planning, HIV, sometimes you have other obstacles that you're concerned about with confidentiality as far as calling patients. We do want you to think outside the box. Think, you know, maybe the preferred method, which you're going to get that information when you do the appointment scheduling or pre-registration, how they would like to be contacted so that you can make sure that confidentiality is maintained. So you can text. There's ability for cell phone or emailing. There's different ways of getting in touch with the patient, reminding them of appointments. We also recognize that a lot of your appointments are only made the day before or 2 days prior to them coming into the clinic. In those cases, it's very difficult to be reminding them. Sometimes you don't feel you need to remind them of coming in. But it's, you know, that you still have that capability of texting. And you can set parameters that you only contact somebody if they made their appointment 3 days in advance rather than the last day or so. So it's a big value to have a reminder contact for the patient. It's just that you do need to think of how your clinic operates and what works best for you.
So then we move to the check-in process, and of course, if you have not obtained information in advance, this is the opportunity to get the patient's information, both their identity and their insurance information, and confirm the reason for the visit.
Now, as far as the check-in process too, I want you to keep in mind another reason why pre-registration is helpful when you schedule an appointment is your front desk staff have to often schedule patients. They have to be answering the phones. They have to be scanning insurance and ID cards. They have to be collecting all the HIPAA forms. They have to be making other appointments. There are so many things coming at them at one time. By pre-registering, it helps to eliminate some of that. And also, those few patients that you do have same-day appointments or walk-in, your time is going to be focused on, those patients too. So one other thought that we've seen in some of the clinics is that maybe the phones can get diverted when the clinics are actually seeing patients to another person, so it's not ringing at the front desk when they're trying to greet patients and collect that information.
Confidentiality.
I did want to, Nancy, thank you. I did want to mention the confidentiality. Time of registration or when they come in, that's a perfect opportunity on your patients that have private insurance that will be submitting. If you want to offer them the option of confidentiality, there is a form the Maryland legislature passed last year that patients can have their EOB's explanation of benefits from their insurance companies diverted to
Organization, you want to make sure you have complete patient registration forms, that the HIPAA forms are signed and completed, that you've scanned both the insurance cards and photo ID, and this is the opportunity to collect both co-payments and any outstanding balances.
I did want to mention one other thing. When you're checking, we're going into eligibility now, but when you have your front desk people, they need to be educated as far as knowing how to read and managed care Medicaid MCO cards, because often we have found that the patient's Medicaid number is being used and put into the system rather than the patient's member or subscriber ID number, and that's when a lot of claims get denied also. So that was one of the lessons that a lot of local health departments have recognized, and they're trying to make sure they reduce those denials.
Okay. So again, if you haven't done any pre-registration, that again at check-in, this is where you're going to need to verify that the insurance information that you're obtaining is accurate and that the patient is eligible through their payer for services at the date of the visit.
What's nice with the eligibility verification, if you have a practice management system, you can do it electronically, and most all the practice management systems allow that. It goes directly to the clearinghouse to verify your benefits and deductibles and copays for the clinic. Also, if you don't have a practice management system, you can always verify eligibility through the web. Every payer has that capability, or you can go through the phone.
We wanted to make the point, and Chris alluded to it earlier, that the front desk receptionists or the front-end functions have typically been done by the kind of least experienced and least paid employees in the organization. Where we have had the best success in maximizing revenue and reducing outstanding accounts receivable is when we've brought more experienced staff into the front end of the process. In fact, even bringing billing staff at times to the front desk means that you'll get cleaner claims, fewer denials, lower accounts receivable, because you've got people who understand the importance of getting that information. If you have a clean claim, you really have very few accounts receivable, so you could probably reduce the billing staff because you're getting paid more accurately. If you can't bring the billing staff, and some of you have your billing offices and the functions remote from your clinical site, you really need to create the partnership between the billing office staff and the front office staff, whether it's meetings or good communication. The more that those two pieces can be married together and communicate on a regular basis, the more effective your billing process will be.
There, we often see there's a lot of stress between the front office and the billing office, and sometimes even the clinical, because billing office gets to see all the mistakes and all the denials, and they get frustrated because I think if people at the front end or the clinical would do code right, document right, or collect the right information, we wouldn't have all these denials. But they're also not on the front end when they have patients coming at them, and they also, the front end, like Nancy said, don't always have the training or the education or the resources that the back end is able to deal with. So yes, that communication, meeting on a regular basis is nice. Getting to see people face to face, it's hard to be angry at people sometimes when you see they're really human on the other side. And also creating a tool. We've often created a tool that is a communication sheet. So the back end can say, okay, this claim is denial for this, this, and this. Can you fix it? It's educational. It trains the front desk so they understand where they need to improve, and just keeps the flow and the revenue cycle going a lot smoother.
Okay, we're going to move on to charge capture and coding, everybody's favorite area. I know you've heard it before, but I think we can't emphasize enough that the clinical services have to be properly documented, coded, and captured as charges for billing. And the best thing to accomplish this, at least in terms of the charge capture side, is having a super bill, charge ticket, encounter form, whatever your organization calls it, in either a paper or electronic format. And the importance of submitting those, completing those notes and the encounter form and getting those charges into the billing system in a timely way, we just can't emphasize enough, because when you fail to get those claims in on a timely basis, it really impacts the cash flow and increases the likelihood that the service is going to be denied.
Okay, and I'd like to address this. We're seeing that now we have two methods of capturing charges. One is going to be the practices that have the electronic health records, where the provider is actually checking off the codes and their level of services in the system. And the other one is the paper form, where often the front desk staff or sometimes the back office staff has to literally manually key in each one of those codes. So one of the problems with the electronic health record, there's great benefits. They have a calculator to help calculate the E&M service and things like that. But to trust that the provider is not going to miss the opportunity to capture some of the charges, and the charges are ready to go out for billing at that point for claims, is a very dangerous place to go. We found that there was one health department that the practice management system had the charges, the codes linked to the billing for all their services except for their E&M services. So thankfully, a front desk person was very on tune to things, and she was double checking what the providers were billing and noticed that none of the services they had any E&M services, the evaluation management services on. So consequently, if she hadn't caught that, those things weren't being billed. So there are some things you have to be careful of. Also, if you do have an electronic medical record and you don't need a super bill any longer or an encounter form, please consider having something like that available for the providers as a quick reference near their stations. You don't have to have a lot of paper, because some of the health departments said they're reducing, they don't want paper. But you can laminate a sheet with all the key codes. It just helps to trigger and remind the providers about codes, so you're not missing the opportunity to capture all your charges.
I can also make the point that these codes do change from year to year, so it's very important to have someone in your organization who's paying attention and making sure, because I think what we found when we went in is that many of the health departments were using obsolete codes, inaccurate descriptions of codes, so having a really up-to-date super bill is extremely important. So moving on to documentation, this is really an area of exposure now for the health departments that are submitting, that are participating with payers, and you are submitting claims. Now you're subject to audit. And the payers, the predictions are that every health organization, private practice or public, is likely to be audited in the next 12 to 24 months by at least one payer. And what the payers really are looking at is, does the documentation in the medical record support the claim, the codes that were submitted? So the principles for documentation are, if it's not documented, it didn't happen. If it can't be understood because it just doesn't, the documentation doesn't flow in an understandable way, it didn't happen. If it can't be read, if it's not legible, it didn't happen. If it didn't happen, it should not have been paid. And if it documentation and recommended guidelines, so it's important if you are contracting with payers to look at their specific requirements, that documentation has to be timely and well organized. So moving on to coding, certainly we've made reference to the evaluation and management codes, and these are used for the treatment of most of your conditions. The primary is for initial visit and the follow-up visit, for family planning, contraceptive management, and discussion of counseling and education. And I think the issue there is that for many of you, doing the types of service of the visit and the time spent, and that can be coded as an E&M service with the amount of time indicated. As you do, it may be that counseling and education are the primary and then can possibly support a higher level code than you would have with just the straight E&M service.
And we do recommend you write your start and end date time on there.
So just some successful tips for E&M coding. Make sure you know what documentation guidelines you're using, whether there are both 95 and 97 guidelines. Either one is acceptable, but you need to know, primarily use one or the other. There should be some type of both initial and ongoing training for providers and billing staff on your coding. The stronger your templates can be, the easier and more complete your documentation will be. Really make sure that the provider's documentation supports medical necessity for the service, because again, that is what the auditors are looking for. Modifier 25, Chris is going to mention use of that, and then just know the new and established patient rules, because you may have patients returning that haven't been with you for a number of years, and typically 3 years is the period that the payers will use so that a patient can be coded as a new patient. Right?
Yes, as far as the modifier 25, I think that most of the local health departments that we've gone to, we've already kind of gone into this in some depth. But a typical example would be if you have a patient coming in and they're getting a preventative service or physical, as you might call it, and being seen, but they're also presenting with a medical issue, a medical problem, whether it be a rash or whether it be for STI or whatever, and you're evaluating that along with doing a comprehensive physical exam. You can bill both those codes with the modifier 25 appended to it. What you need to do is make sure that the physical V70 code for the physical evaluation goes on the preventative visit, and that the diagnosis for whatever medical reasons you're treating the patient, that goes on the E&M codes, the 99212, 213, 214, etc. So that's very important, because a lot of times there is missed opportunities for gathering the revenue that you need to for those services. I will point out that one of the problems or one of the complaints that some of the health departments said is if we use an E&M service and a preventative visit with the Accountable for Act, and they don't have to pay a copay for the preventative visits and services, but If they have them for an office visit, an E&M service, the patient may have a copay, and that's true. And there's no way to really get around that because legally that's what their responsibility is. But you don't want to minimize what your reimbursement is. You need to maximize to keep your clinics open. So you need to consider those things as you're coding your visits.
One of the things we suggest, and this is what we do when we go into your department to do any kind of revenue cycle management, is actually following the path of the encounter right from the time that the clinical services are provided, shadowing your providers if you haven't done that before, to really make sure that their documentation supports the services they've provided, looking at the accurate coding, and then having a process to make sure that, and some reconciliation process to make sure that all the services are billed both correctly and completely. Importing codes from your EHR certainly continues to help with accurate code selection. We mentioned already updating your encounter forms or your super bills to make sure that they don't have obsolete codes. Connecting the diagnoses to procedure codes sometimes is mapped out in your EHR so that it just facilitates that connection. Verifying the accuracy of codes. Auditing your encounter forms is an important process that needs to be embedded somewhere in your departments. And then that opportunity for continuing education and feeding back to the providers on coding accuracy.
And, you know, when it comes back to the electronic health records with the providers, a lot of this practice management systems in the EHR, they set up so that the codes automatically, when the provider checks them off, goes over to the billing. But again, we've seen where some of them are set up to pull over and some aren't. So when you do your auditing for your charge capture, make sure that your practice management system, your EHR, is set up to pull those codes, and don't just assume that because they're pulling some of them, they're pulling all of them. So that's where it needs to be audited. Many of the health departments and a lot of the medical practices that we deal with will all, when they start going with an EHR and the provider services, they will have the provider still do a super bill initially, so that they can do a comparison and make sure that what's going in their EHR is matching what's on the super bill. And most times, until the provider gets used to using EHR, they'll find that a lot of charges are missing. So it's a time of training and education and reinforcing to make sure that you don't have a period of time that you don't identify missed charges. One other issue that we have often with the EHR with providers is they don't always finish their clinical note in a timely fashion. A couple of the health departments had a timeline of 24 to 48 hours it's required. When the providers use a super bill, they have their charges in right away, and usually they have their documentation, which they need to before you bill. The documentation needs to be there. Just as an awareness that, you know, it's urgent, that you can't bill until everything's documented. So you need to make sure that there are some pretty strict guidelines and enforceable guidelines with the providers to get their documentation done, encoded in a timely fashion.
And good luck for that.
And good luck.
So we've done all this work now to get the right information up front. We've been working with your providers to make sure they know how to code and document properly. One of the things that we typically found missing, though, was an actual reconciliation process within the department to make sure that actually all of the services that were provided for that day were actually captured and able to be billed. So some of the suggestions we have for charge reconciliation is to use some visit tracking reports. Either, again, they may have to be manual, or you may get them through your electronic health record that help to identify no-shows and missed charges. There needs to be an end-of-day reconciliation process at some point so that the charges that are posted into whatever system you're going to use for billing are reconciled back to source documents, the super bills. They also need to be reconciled back to sign-in sheets or your appointment schedule so that you have whatever the source is of actual patients seen that day matching up with what's in your billing system. We often find that some of the additional, so the visits may be captured, but then some of the additional services that are provided, whether they're, your injectable or billable supplies, that they aren't necessarily entirely captured in the billing process. So any logs that you have, whether they're manual or embedded in your system or an inventory control system, will be another good source for determining whether or not, if your inventory goes down by 20 by the end of the month of a certain injectable or supply, is there evidence in your billing system that 20 of those things were billed out? And again, Chris mentioned, just we can't emphasize enough the importance of trying to get those charges posted within 24 to 48 hours.
Often when we went to the health departments, we saw that they were doing the reconciliation end of the day. And we saw that they have good inventory control, like for your vaccines and all, as far as what you're ordering and what's come in. But we don't see where the inventory goes that's compared to the billing system accountable. And up to this point, a lot of it's because you haven't billed. And so they're not billing, they're not recording it, they're not tracking it. So that is a problem that needs to be put on the reconciliation process for a lot of health departments.
Okay. So moving to the back end, we're going to talk about claim submission, and that just means the process by which the charges actually go out to the payers. As you're building out your billing system, are you filing claims? Do you have the capability to file claims electronically? If possible, you should be trying to use a clearinghouse. Hopefully you have pretty high functionality in your practice management system that does that scrubbing, initial scrubbing process. That there are claims reports that you can preview before they go even to the clearinghouse. And those errors should be corrected prior to submission. And most systems then have both submission reports and acceptance reports, so you can see that your claims actually reached the desired location.
And I can't emphasize enough about previewing and editing your claims for the GOT. Even if your system does have editing process with it, you need to look at it. Some of the health departments are having the charges after the provider's done them. They're not reviewing them. If the system allows it to go through, it just goes through. And those are having higher volumes of denial. So it's something that Clean Claim, is going to indicate, or get your claim processing your money in a lot faster. If a claim isn't clean, gets denied, it's a lot more work on the back end to do an appeal and a resubmission.
Hopefully, if you do have a practice management system, you are working through a clearinghouse. That's a private company that really provides the connectivity between the providers, the billing entities, and the payers. It greatly enhances the transmission and the payment of those claims. It is primarily electronic. And if you don't know who your clearinghouse is, you should be contacting them, because there may be many functions that they can provide that you haven't even taken advantage of. And again, in your departments with limited resources, anything that can be done electronically or through these clearinghouses will reduce the requirements on your own staff.
Many of the clearinghouses have their own scrubbers, so if your practice management system or something gets past your billing people when you've pre-edited your claim, The clearinghouse may pick it up. I did want to go backtrack a little bit and say one thing that we did find, that some of the health departments weren't submitting claims, but maybe once a month, 6 weeks. Claims should be submitted every day if possible, or any clinic day. They shouldn't wait. You have timely filing limits. The state of Maryland allows 6 months for a claim. There are Medicaid, Medicare allows 12 months. But you need to get that claim in, and it's all based on date of service, not based on date when it's received. So that's extremely important, and one of the problems that we did notice a lot when we came out to the health departments. When Nancy mentioned about the features and functionalities also about the clearinghouse, I can't emphasize that enough. Most of the clearinghouses, yeah, well, they definitely will give you confirmation that they've received their claims. But a lot of the practice management systems don't always pull the information back in from the clearinghouse into your practice management system. So if a claim fails an edit at the clearinghouse level, you have to go to the clearinghouse to get those reports. They won't go to the payer if they fail the edit at the clearinghouse. It's something that you need to go in. It identifies who the payer is. It identifies what the problem is. It's easily for you to fix and refile the claim. The other thing is, if it passes the clearinghouse edit and goes to the payer, oftentimes the payer may find something that isn't right, and they may not even begin to process the claim. It won't go past them to go into their system to be adjudicated. It will simply sit there, and they'll notify the clearinghouse that there's problems with the claim. Again, those reports, usually the clearinghouse reports are real time. The payer reports that come back that there's denials from their scrubbers maybe a day or two. So it's extremely important that your billing staff understand about the software with the clearinghouse and whether they need to go in and retrieve that information and fix it. So often we see that billers maybe 6 months down the road will be calling Care First and saying, you know, checking claim eligibility or claim status, and they find out there's no claim on file. And they look and they've submitted that claim 10 times, 20 times, and I'm not joking, I've seen this. And the reason why is because it's sitting at the clearinghouse. It never got entered because there was some technical problem with the claim, so it never got in, so they don't get paid because it's timely filing. So that's just a big alert to let everybody know that that's important. They also have dashboards. Most of your clearinghouses, MDON, Gateway, they have a great dashboard. It shows, you know, pie graphs. You can look at it. You can see your denial rates. You can see which payer. You can see the denial reasons, the volume. It's a great way to be able to monitor your billing staff to see how efficient the billing is going out.
Okay, we're going to move on to, so assuming that claim has found its mark, then what comes back from the payer is either called a remittance advice or an explanation of benefits. And it will detail how payments were made or the denials that were applied. So in terms of payment processing and monitoring, the things that will really enhance, again, this whole process, first, find out if you have not already, if you can enroll in the electronic funds or the EFT process. Most payers now are set up so that they can transmit payments directly to, whether it's a lockbox or your bank account or whatever the, you know, wherever the funds are to be received, so that there aren't checks in the mail or any funds going back and forth. And it obviously speeds up cash flow because that payment goes directly to your bank account. Similarly, the remittance advice can and should be coming in an electronic format, and that will allow, again, reduced paper. It allows for the billers to review that online and to have those payments posted electronically. Most of your software will track payment variances, so if you can embed what you are expecting in the way of payment from the payers into your practice management system. Believe it or not all payers always pay their contracted rates. So that's something, if you can, particularly for your frequently provided services have those expected payments in your software. That's helpful. Always make sure that your fees are above whatever the payment, your contracted rates or what you get paid, because typically fees, if you're getting paid at your fee, then it means that you probably aren't maximizing payment and should be able to increase your fee. And finally, training your staff to monitor contractual adjustments, and even unbundling some of the edits will help to make sure that your payments are monitored and paid properly. We've made this point before, but timely posting, not just of the, or timely submission of claims, but also posting of payments is really important. We found in many of the cases that payments were not posted in a timely way, and when that happens, it really makes it almost impossible to have accurate work on your accounts receivable. If you have undated balances, then you really, or once you update your balances, you can pursue secondary payers or the patients as appropriate.
One of the problems with the payments right now without having contracts, you really don't know what your fee schedule is going to be or your reimbursement. That makes it difficult. I did want to mention also that with the paper simplification through HIPAA and trying to reduce that, Medicare and Medicaid both require that you have electronic funds transfer, that the money goes right into the bank. So when you get an electronic remittance advice or remittance advice that you have to download, you have to make sure that you're comparing, and that's, we'll talk a little about that reconciliation, but that you match up your EOB, your remittance advice, with what you're getting from electronic funds at the bank. And some of the health departments were doing this, others were not. So it's extremely important. We have seen where an EOB will come over, or remittance advice, but then the check never hits the bank. It somehow gets diverted somewhere else, or vice versa. A check hits the bank, but you never get the EOB or the remittance advice, so it gets posted. So that's an issue. Not all of the payers are able to do the remittance advice electronically at this point, so some of them will be coming in the mail, and they will have to be, posted manually, which of course, anytime you do anything manually, then you have a higher incidence of errors. We also wanted to point out that a lot of times when the electronic remittance devices come over and your system can post it electronically, you still need to review that, because often, Medicare is one I see a lot of times, they'll deny it and the payment or the balance will be adjusted off as a denial. But in reality, you really need to appeal that, and you shouldn't be adjusting it off. So make sure that you just don't trust, just like you don't trust the providers always making sure they're charging correctly, that you don't trust what these EOBs are coming in, the electronic remittance advice are posting, that they're posting it correctly. You can't assume that, because there's a lot of those that will be denied that can be appealed.
And Chris made the point, but we just want to reinforce, if you're not already comparing your payments posted to your billing system to your bank account at the end of the month, it's a very simple and critically important reconciliation, because checks cannot always and may not always reach your bank account, or a check's been received and the EOB hasn't been received, so it can't be posted. So that just reconciliation process just between what's posted at the end of the month, billing system, and the money in the bank is a very important thing to check.
So this opens up communications, not just important between the front desk and the billing staff and the clinicians, but it's also opening up to your fiscal department, that there has to be some kind of communication back and forth.
And Chris already covered how to get electronic EOBs, that they're either through the website or they're downloaded by your practice management software. And the payments either are mailed in, EFT, or now we've seen that, and I'm sure you have too, that some of the payers, even the MCOs, are actually paying with credit cards.
Right, you'll get a voucher, one-time use, you will need to punch it into your credit card machine, Just make sure I've seen it, that it doesn't seem to go any further to get posted in the practice management system because it's a new method of payment. So just be careful of that.
Again, hopefully if the claims are clean, then you really don't have a really extensive AR management issue, but you certainly need very clear processes and procedures for tracking claims that have been submitted and following up on the claims that are either denied or not responded to.
And please keep in mind when you file a claim, if it's gotten processed and denied, that your timely filing clock resets. Some only have 30, 60, or 90 days to appeal. So it's a lot more limited. So you have that 180 days to a year. Once it's been processed, your timeline changes drastically. That's why we say you need to appeal denials immediately.
I think these reasons for management denials that we're looking at right now really speak back to the team effort and the fact that everybody is involved in the billing process. These are some of the top reasons why claims get denied: demographics, lack of medical necessity, lack of pre-authorization, untimely filing, duplicate claims, or needing additional information or coding. And you can see demographic errors would be at the front desk. Lack of medical necessity is a provider issue. Pre-authorization, front desk. Delays in timely filing would be the billing staff. Duplicate claims would be at the billing end. Additional information might be clinical, might be front office, and coding errors. So it's really these reasons for denial and why claims are denied could be at any point in the organization. And it's important to try to really look at the frequency of those denials so that you can not just have the back-end staff fixing them, but actually change process at the front or clinically so that those denials don't continue to happen.
And typically when Nancy showed that prior slide, when it's a duplication of claims, typically it's Care First Blue Shield. If a claim is denied on the EOB and not processed, you can't simply just resubmit it. You have, after you've corrected it, you need to do a form. So understanding what the payers want, you know, a re-evaluation form, you know, whatever they require in order to do the appeals. Some payers you can just go ahead and resubmit it with the corrections, not a problem, but other ones you do have to go through another formal process.
You're going to get more information if your staff, if you have the administrative payer manuals, other program manuals and policies, access to the newsletters and updates for provider bulletins, and web access to your fee schedules and claim management.
And just to let you know, you do not have to be contracted with a payer in order to have access to those resources. You also can sign up with a payer to be on their provider portal and check claim status, again, even if you're non-participating. And eligibility is another thing that you can. So that's a great resource to keep up to date on the payers.
As you're building out and strengthening your RCM process, make sure that you actually have written procedures for how your billing staff should be tracking and working your outstanding insurance claims, because otherwise it becomes it's sort of the area that gets the least attention. You know, typically billers will focus on getting claims out the door, they'll post payments, but the AR is the thing that often doesn't get addressed unless there are very specific procedures for how frequently and which they should tackle first, and kind of a formal policy. Definitely having relationships with your third-party provider reps as you contract with them really will help to identify if you have things that are denying, or if there are issues about or trying to pursue outstanding balances.
And that's where we're going back to the front end with the appointment scheduling and pre-registration. It's a perfect opportunity to let your patients know your financial policy up front and what's expected and what they need to bring.
So we kind of moved into patient billing. Certainly patients need to be billed either after their insurance has responded or if they're uninsured or don't wish to bill their insurance company. And you need to make sure that you have compliance with payer requirements before you bill patients if it is, you know, an uncovered service or something that is due from the patient either through a high deductible or co-insurance.
So often when we went to health departments, we found that the patient billing was really lacking, that sometimes it would be 6 weeks, a month, or
patient statements.
There was no continuity on when they were being sent out. It was one of those things that kind of went on the back burner. It is really important, if you get an EOB, patient has a balance remaining, is to get that statement out to them right away. Because otherwise they're going to forget. You know, they'll get other EOBs coming in and they won't remember their obligation, and that increases phone calls. They get annoyed when they start seeing statements come in. Plus, their practice management sometimes will have dunning notes if you have them set up, and it may show that they're past due because the time is 90 days past when they had the service, and they'll get a note that's past due and they've never even gotten a statement before. So we saw that the patients were pretty upset and they were getting a lot. The billing office getting calls that way. So that's very important.
I'm sure you know that most patients don't even understand what the terms often are of their insurance plan that they've signed up for. And it used to be that about 10% of most practices' revenue came directly from the patients, but because of the increased deductibles that are going into most plans and co-payments, that percentage is now approaching 40 to 50%. So more than ever, having clear financial policies, knowing what you can and can't bill your patients for, what your organization is prepared to do in the way of pursuing your patients for payment is critical for the system.
So it's a lot of confusion out there as to what you can bill for, who you can bill for, and it's changing on a regular basis. We don't even know what the non-chargeable list will be until the end of this month. So those are very important things to keep in mind as you're developing your policies and keeping them up. I did want to say one other thing as far as sending out patient statements. We always recommend that you send out patient statements on a cycle. And what a cycle means is to set up your practice management system so that you send bills on a weekly or bi-weekly basis. It helps your cash flow. What your system will do is if it's set up that the patient's gotten a statement within the last 30 days, they won't get another statement. It'll just pick up those balances and those accounts that haven't been billed in that time frame. If you do it that way, you'll be billing your patients pretty quick after their EOBs have come in if there's patient balances. And also, like I said, it helps your cash flow. Your patient call volume will be more evened out. It will be less stress on your staff. And do electronic statements whenever you can. Almost all practice management systems and clearinghouses can do that for you. And what that means is you'll be sending an electronic file over to the clearinghouse just like you do when you're sending out claims. The clearinghouse within 24 hours will have that statement out to the patient. You know, they'll have it printed out and they'll send it to a patient with a return envelope. Like I said, within 24 hours. It's very clean, it's very professional looking, it's so much easier than your staff having to stuff statements. There are reports in most practice management systems that you can look at ahead of time to go through those accounts that you want to pull out and flag so don't get statements. So you don't lose that control that you think you have when you have statements. So I've seen in the health departments people sitting there with stacks of statements, and that's why they don't get out. And If you're printing them to paper, they may never get out, and yet their system is tagging it that they've been sent. And the same thing with your paper claims. We see that happen too a lot of times. So just use as much automated system as possible. And when you set up an electronic statement with your clearinghouse, make sure it's legible and clear and for the patient to understand.
Okay, lots of information. Hope it's helpful. Now that you've done all this work, it's important to know whether your process is effective. And so that's what the benchmarking or key performance indicators, KPI, help you to do at a management level. So we're going to talk a little bit about what some of those key performance indicators are. You should have, from whatever billing process you're undertaking, you should have a set of monthly management reports. Whatever claims have gone out for a month, whatever payments have been posted, there should be a hard close to the month end, so that then you're able to obtain a report that shows your charges for the month, your payments for the month, and that it's run consistently at each month end so that you then have comparative data. So we call those key indicator reports, or it's a dashboard, but it really helps you monitor the financial health or the effectiveness of your revenue cycle. So those key month-end statistics include total charges for the month, total payments for the month, the days in accounts receivable, your AR aging, so of the claims that have been submitted to the payers, what are in a current status, what are 30 to 60 days old, 60 to 90, 90 to 120, and over 120. Again, most state-of-the-art practice management systems produce these reports on a routine basis. Collection ratios help you determine what amount of your fee is being paid by each of the payers. And then an aging by payer will tell you if there's a particular payer who is ignoring you, or perhaps your claims aren't reaching that payer. The denials, we talked about tracking those to look at patterns, and then really looking at, from your E&M codes, your total volume of new and established patient visits will help you know if your practice, if you're seeing increasing numbers of new patients, again, to help plan for staffing, for the growth, if that's a goal of your organization, whether you're losing patients. So tracking these on a monthly basis and then a year-to-date basis will really help you determine how your organization is doing. Finally, we're going to talk just briefly about the auditing process. I mentioned earlier that kind of the good news, bad news about being contracted with the payers. It then exposes your organization to outside audits. So every one of your departments should have a billing compliance plan. It's a formal document. The OIG said it's not a requirement, but it's a guidance, and it's really a recommended plan that shows that you are really working to have a compliant billing process, and it's a plan then that anyone coming into your organization can review and understand what exposure and what responsibility they have being part of the billing process. Having an internal auditing process to actually look at what documentation the providers did and whether the codes were supported by their documentation is a very important process. For most, if not all of your health departments, SHR has come in and done independent auditing. So we are often independent consultants to come in and help you establish the baseline for that audit process, and either then work with some providers or administrative staff to embed that process in your organization, or we can come back on a 6-month or annual basis and help you do that process. And then doing ongoing education for the providers and staff based on the results of those audits to just continually strengthen your billing process. So I think in summary, we've kind of reached the end of our formal presentation. Try to create some type of revenue cycle management team process in your organization so that you have regular, ideally monthly meetings, that you can share those key performance indicators with front desk, clinical staff, billing staff, ideally in a team environment so everybody understands how effectively you are doing your billing. Where possible, you may want to benchmark against industry standards. The dashboards we talked about really help very much to tell you whether you're monitoring and improving your revenue cycle process. In billing and collections. And with all the challenges facing your organization today, we feel that investing in improving your revenue cycle performance is probably one of the wisest investments you can make. So I think on that note, we just want to mention that in the handouts you received, we've provided a glossary of terms because moving into insurance billing, when you haven't done it before, introduces you to a whole new term, glossary of terms, RA, EOB, EFT. We've talked about a lot of them today. So we've provided you a glossary of terms. We've also provided a guide for selecting a practice management system. And the reason we did that, many of you have some billing system already, but it shows you what the key features should be in a state-of-the-art practice management system. So to go through that process, look at your system and say, do we understand whether we have that capability? If we don't, can we talk to our vendor about it? Or maybe we just haven't taken advantage of that feature is very important. So that's why we thought it would be helpful to give you that guidance. And finally, actually Chris has developed for us an RCM, Revenue Cycle Management Action Plan. It's the tool that we use when we go into your department to really do that revenue cycle assessment, and we thought it would be helpful then for you to do your own self-assessments on an ongoing basis.
And I do modify that action plan depending on the health department and depending on the department that we're looking at. I did want to say also about the practice management system that Nancy was mentioning when she said about turning on features and functionality. I've seen this a lot in the health departments, the electronic eligibility, they don't know that. Capability or the ERA, they don't know. And some of it's already paid for, some of it will be ancillary costs too. So that's something
the cost-benefit analysis
yeah.
you'll have
just
to
like
do.
the electronic statements, believe me, it's a wipeout as far as what you're paying your staff in paper and the printing and all compared to what you're paying for having electronically.
So I think we're going to turn it back now to Christine. There are some questions. Christine and Elizabeth, perhaps?
Hi, this is Chris. I'm not seeing any questions come in. So if anyone has anything, please type it into the chat box, and we'll just wait a moment to see. Although that was a very thorough webinar, I'm not sure we'll have too many questions.
Maybe they're all asleep. I don't know.
And if anything, no,
hopefully
absolutely not. I'm sure if there's any questions that come in you think of after the end of the webinar, please feel free to send me an email, and I'll share them.
Chris,
absolutely.
can you hear me? Hello.
Hi, Elizabeth.
Hi. Am I on mute or no?
No, you can speak.
Okay. While people are typing in questions, if there are any, I wanted to make just two points that it sounds like many of the attendees on the webinar today are from Maryland, so I thought it might be interesting to know that we did do a clinic capacity survey of all of our STI programs in the state. And out of the 24 health departments, we had 22 responses. And just an interesting point about third-party billing, 3 of our health departments contract out their STI services. So if you subtract those from our 22 responses, we found that 74% of 19 local health department STI programs are currently billing, and 86% of those that are currently billing third-party payers are actually doing the billing in-house as opposed to using clearinghouses, which I thought was interesting. I actually was surprised at that finding, and this was people responding to, I think, state fiscal year 2015, so it's not completely current, and obviously those numbers and proportions will change. And I also wanted to make one clarification about the law that was passed here in Maryland, which was Senate Bill 790. Both Chris and I think Nancy spoke to explanation of benefits and confidentiality. So just to clarify, here in Maryland, patients are, by virtue of the HIPAA law, allowed to request from their health plans that their explanation of benefits with any details of their sensitive health information, for substance use, mental health counseling, certainly STI, family plan, HIV services, they can request from their insurers that that information be communicated to them through an alternate means of communication rather than mail. They can also request that that information be sent to a different address. The health plans do not automatically necessarily grant those requests, but the patient does have the right to request that if they feel that their safety would be harmed by having that sensitive health information go to their policyholder. It's my understanding that many insurers would grant the request, but they are not required to grant it. And I actually did hear from one health department that said one of our big health plans here was asking for some kind of documentation or proof that the patient had a history of potential, intimate partner violence or domestic violence to kind of bolster their request, which is that's not appropriate, and I'm following up on that. But so it's not an automatic granting of a request for alternate communications for confidentiality, but the patient can request it. The health plans do not automatically have to grant it. And that was it.
Okay, thank you. I'm not seeing any questions come in, so I think we're going to wrap things up. I do want to remind everyone that next Wednesday we have another webinar on the ICD-10, so you're welcome to join us for that, and that one also will be recorded. And I also want to remind everyone to please fax me your sign-in sheet and evaluation so we have a good record of who attended this session. And I want to thank both of our speakers and Elizabeth for participating in this webinar. Is really useful, and really I feel it's going to be very helpful to all of us. So thank you, and enjoy the rest of your day. Bye-bye.
Thank you.